All right, welcome everybody. I know that this is always an interesting opportunity for us to get together, and today what we're going to do is a little bit different. So we're going to focus much more on the professional side. We're going to spend a lot of time hopefully breaking down kind of what OCD is, what PTSD is, and how you treat one or both at the same time. We'll give everybody a couple of minutes to join. We're starting early, which is great, but we always want to give people a few minutes. And so I want to encourage you, go ahead and post comments in the comment section. Let us know who you are, where you're calling from or joining from, and also your background. So are you an individual with OCD? Are you a professional who treats OCD or PTSD? And then again, just so everybody knows, the comment section will be used throughout. So please make sure any questions, comments, thoughts that you have, post them throughout, and I'll be sure to do my best to navigate those questions right and kind of push them right into our live stream today. As always, a couple disclaimers. So thank you so much to the IOCDF, who is hosting this webinar and who hosts these webinars constantly to continue to bring top of line content to those who need it the most. The second is to make sure that we just cover a couple things. So this is not treatment. This is not intended to replace treatment. So while some questions might be treatment focused, we'll give general feedback from a professional stance, but we're not giving specific treatment recommendations. And as always, if you're feeling unsafe or suicidal, please call 911, go to your local emergency room, or call the suicide hotline. This platform, the IOCDF's platform, is not a platform if you're in crisis. So let's go ahead and get started. So today we have Dr. Wetterneck, who you guys can see joining us from Wisconsin. I'm sure the weather's a little bit different for you, Dr. Wetterneck, than it is down here in Houston. So we'll hear about that in a second. But let me just take a second to introduce Dr. Wetterneck. He is a licensed psychologist who serves as the clinical director of trauma recovery services at Rogers Behavioral Health, where he developed the adult trauma recovery programs at the residential, partial hospital, and intensive outpatient levels of care, and has helped to incorporate a cognitive behavioral therapy-based approach into Rogers' addiction and mental health recovery programs. Dr. Wetterneck completed his doctoral in clinical psychology at the University of Wisconsin-Milwaukee with specializations in child psychopathology and advanced statistics, and he completed his internship right here in Houston at the Baylor College of Medicine and the Menninger Clinic. In addition to his position with Rogers, he holds adjunct faculty appointments at Marquette University and the University of Wisconsin-Milwaukee. He's published over 75 peer-reviewed articles and has co-authored a book and has been grant-funded for studies on treatment outcomes. Dr. Wetterneck has spoken at the national and international conferences on PTSD, interpersonal intimacy, and multicultural training. He's won multiple awards for research and teaching, including the Baylor College of Medicine Research Award and the Most Outstanding Educator in Counseling at Marquette University. He's a member of the American Psychological Association, the Anxiety and Depression Association of America, ADAA, the Association of Contextual Behavioral Science, and the IOCDF, as well as the International Society for Traumatic Stress Studies. I've worked with Dr. Wetterneck myself on different research, and we continue to collaborate. As all of you know, both Rogers, McLean in Houston, McLean in Boston, right? We all collaborate and work together, and we couldn't be more excited to have you today. We're excited to hear your expertise, both with your OCD background, anxiety background, but specifically trauma background as well. So thank you and welcome.
Thank you, Dr. McIngvale. It's nice to see you in person and to be chatting with you today.
It's fun to be here as always. So hi, everybody. I know so many of you are posting questions saying hi, good to see you. We've got people from all over, from North Carolina, Texas, and all around. So thank you, and please post questions as you have any that come up. So let's just start with a little bit of an introduction. So we talk a lot on these webinars about what OCD is. And we talk about the components of OCD, right? Obsessions, which are unwanted, intrusive thoughts, and compulsions, which are repetitive behaviors that the individual does to get rid of the anxiety and distress that those intrusive thoughts cause. Can you tell us a little bit, let's start with kind of breaking down PTSD. What is PTSD? What does it look like? What are some of the diagnostic criteria? How might people present with it?
Yeah, so, there's really two main diagnostic criteria in OCD, right? The obsessions and compulsions, and then a lot of it has to do with how much you're having them for and how they interfere with your life. And PTSD is really 5 areas, and then depends on how much it interferes with your life as well. So the first area is, and this is one of the big things that differentiates OCD and PTSD, is that something must have happened in your life that you perceive to be life-threatening. And that's not as clear of a differential diagnosis as I'd like, but typically the first criteria for PTSD is you have to have something directly happen to you or happen in your presence or observe something that you think threatened your life. Those things are typically something like some sort of assault. It could be physical in nature, sexual in nature. It could be an environmental event. When I was in Houston, it was hurricanes. Up here, we're in Tornado Alley. It could be a car accident, an explosion, and it could be like a lot of sustained long human suffering as well. So if you're deprived of food or you didn't have your basic needs met for a long period of time and you thought that could result in your death, there you go. You've now encountered something that you think is life-threatening. Perception is a really big piece of this as well. So you could have been put in some place or experienced something where you thought you could have died, and it's possible that you could have, even though you might find out later on that death may not have been an option. It doesn't mean that you didn't meet the criteria for experiencing something life-threatening. The next thing that people have is some sort of re-experiencing of that event. So this can look in a number of different ways. There's really 5 different areas. I'll probably only talk about 3 though. But the ones that most people know about are nightmares or flashbacks. Nightmares obviously happen at night. They're typically about the event that you experienced, but not always. So if you had some sort of accident or assault, you might have something where you feel really out of control and maybe you're being chased and can't really see who it is. But anyway, it doesn't have to be exactly, but it is often very related to whatever your event was. A flashback is something that happens while you're conscious. However, it almost seems to distort some of your perceptions. So you might perceive your environment as if the traumatic event is happening again. It's almost like the difference between seeing something on your television screen versus going to an IMAX theater where your senses are immersed and it seems very real to you. There are also other opposite ends of the extreme of re-experiencing. These are obviously harder to study, which will become obvious once I share what that is. Some people do not remember the event at all or events at all. So you can almost get it's not really amnesia. I look at it as your brain's way of trying to protect you in any way possible from coming back into contact with that, which leads us to the 3rd area, which is avoidance. Most people are trying to avoid aspects, both internal and external reminders of it. And it's not just one thing. It's very similar to OCD. Like if you start fearing one type of contamination, you often start paying attention to other things that are related to contamination. The same thing with PTSD. So you get in a car accident with a blue car. Obviously, you're going to be heightened while driving, while seeing other blue cars. But next thing you know, it's any type of vehicle. It's driving maybe anything at all. It's not even driving in the same setting. And people try to avoid doing those behaviors, but they also try to avoid the internal reminders. Now, keep in mind what happens when you're in a traumatic event is typically most people will feel very helpless. They'll feel incredibly anxious. Some people might feel a little bit numbed out, but normally after the fact, it'll hit them at some point in time that this was life-threatening. Those are also things that are part of the traumatic event. So people are literally trying to avoid feeling. And they end up on one end of the extreme or the other. They either become very emotionally numb, or they look, and I don't really love this term because I think it's more a sign of one trying to protect themselves, but they almost look like their emotions are dysregulated. Like they're really wearing them all the time and feeling them and much more sensitive to emotional stimuli, and their reactions are stronger. Anyway, so avoidance is huge when it comes to PTSD. The next 2 areas are change in your alterations in cognitions and mood. This can be comprised of a lot of different things, but if I had to sum it up, it's you get changes in your emotional experiences. So one aspect might be you become more emotionally numb, but if you do experience emotions, you're likely to be more down. Just like OCD, people with PTSD, they avoid a lot of things and they restrict their lives. So they don't have as many of those encounters with pleasurable activity and people because they are really trying to keep distant. Anyway, they might also experience more shame, more guilt. For some people, they might experience more anger, like why did this happen to them? In terms of their cognition, so what are they thinking? There's been a fair amount of research that looks at 3 main areas on what people are thinking, and people generally become more in the mindset that the world is a more dangerous place than what they knew before. They're much more likely for something bad to happen. They find it very hard, or harder than they did before the traumatic event, to trust themselves or other people. And no matter what the traumatic event is, for most people, they take way more responsibility and self-blame for it than other people would. It seems like 95% of the people I work with, they would take all of the blame for it. I shouldn't have been running in that park when I got assaulted and robbed. it's my fault. Like someone jumped out of the bushes and attacked me. Well, that's obviously not true, but that's the way their mind reworks it. And then you have like a really small percentage of the people though that, they feel pretty helpless. So that it's like the world is in control of them and they don't feel like they can do very much at all. The last area is changes in your response to anxiety. So your autonomic arousal system, it's ready for anything to go wrong. You have parts of your brain that are taking ambiguous cues. And if they seem as though they could be dangerous, we're going to interpret them as dangerous. It's going to activate your limbic system. So you become much more aware of anything that could be threatening. We call that hypervigilance. You have a higher startle response. We all have one, but it seems to increase dramatically. You feel more on edge. You have sleep disturbance, a whole array of things. But that's a decent summary of the 5 criteria. And of course, it's got to interfere in your life in some meaningful ways as well, which you can imagine it does.
100%. And I think, as you were going through the criteria, I was really thinking about the overlap that often exists. And I think it'd be a good place for us to talk a little bit about that, because in particular, when someone comes to an OCD clinic and they're kind of, presenting with OCD-like compulsions, there can be an underlying diagnosis of PTSD that can sometimes be missed, right? I've seen it be done many times where it comes up much later, but symptoms like cleaning, right, can shower rituals can actually look like OCD, but could be really at the core a PTSD diagnosis that maybe is morphed into OCD or that looks like OCD symptoms, right? Same with when you think about like robbery or sexual assaults in the home, where then these checking behaviors, right, become really a response to the PTSD event. So can you talk a little bit about that, of when we commonly might see a PTSD diagnosis actually look like OCD and sometimes try to be treated as OCD when really we need to be doing some PTSD work as well?
Yeah, and I want to just take a quick step back and say, I like basing a lot of what I talk about on research, and it's really hard to study some of these things. We don't have a really tight longitudinal study that looks at people from an early age before they might develop OCD or trauma, and then just find out, well, which one happens first or second. And I know you didn't ask that, but that's a pretty common question that comes up. Does PTSD, is it the gateway for all types of mental health symptoms? And I definitely think it leaves us much more open for other things to go wrong as well, in terms of other anxiety conditions, depression, even eating disorders, substance use. But it won't always proceed. And I'm sure you've worked with a fair amount of cases where for some people, it seems as though the PTSD could precede the diagnosis of OCD. For some, it might develop roughly at the same time. And for others, they've had OCD and then a traumatic event happens and then they end up with both. When you're looking for this as like a clinician, you can ask questions, obviously, to your clients, and you can ask whether or not they've had traumatic experiences. What I want you to keep in mind is that, especially if you work more with OCD than PTSD, avoidance is such a strong factor with PTSD. I mean, it is with OCD as well. But with OCD, and if you only have OCD, you might be more likely to tell people and a clinician things, except for maybe some of the more taboo types of obsessions, because you want help. And you think that maybe someone can help you solve this. And and with someone with PTSD, the moment they start saying, yes, I had something happen to me, now they have to think about it. And now it's coming back to them. And the moment they say, yes, I had a physical or emotional or sexual type assault, they know what's coming, more questions about it, and they're going to feel incredibly unsafe. And it's not as characteristic for people with PTSD, especially PTSD alone, to look for reassurance from others, because it means they have to actually come in contact with thinking about how helpless they were in that situation. And I'm not saying OCD folks, they don't feel helpless. It's just, they manifest themselves differently. But you're absolutely right in terms of the overlap of symptoms as well. There is some research on this. We definitely find that, checking is something that likely comes with paired OCD PTSD presentations. And really, it could be any OCD-like symptom or anything we classify as OCD could also develop from PTSD. And it's very hard to tease apart what developed that's more from PTSD, what's more part of OCD. So we might talk some more specifics about how we'd address that in therapy, but I'm not sure if I answered your full question or not. And I might need you you now at this time.
No, that's perfect. So two more questions before we hop into the therapy side. So when I worked at the VA, I was doing my postdoc there, and some of the research that we were doing, what we found is that veterans who had combat experiences and in general with PTSD had a much higher prevalence of OCD as well than the general population, like closer to 5%. Do you see that across the board, that if somebody may have a PTSD diagnosis, it also warrants further OCD screening?
Yes. I mean, I feel like you need the OCD training, if for nothing else, to become competent enough or even expert, like I might say, to help tease apart what part of their treatment needs one type of treatment versus another. And luckily, we have some treatments that operate under similar mechanisms. We'll do them in different ways for OCD and PTSD. But yeah, I think the more, it's nice when people specialize, but the more that you can understand a lot of the high comorbidities, I think the better you are, and the better care you'll receive if you're one of these folks' clients.
Absolutely. And so then as we kind of hop into treatment, I think one of the biggest questions that we get from providers is, does the PTSD need to be treated first? Does OCD get treated first? How do we do it? So if somebody presents with comorbid PTSD and OCD and it's clear they have a dual diagnosis, how do we start and think about treatment?
Yeah, and I wish there was that very clear answer of you always do one before the other. What I'll tell you is based on my own clinical experience. So other people have written about this, but I've also read differing opinions as well. The opinion that I've read the most is that you would likely address the one that's interfering the most first. And these presentations can look, I mean, I could give you a couple of examples of them, but they can look many different ways. So one in which the PTSD might be interfering with the OCD treatment. Remember the goal, and if you're doing exposure therapy, which is what most folks are using to treat OCD, that's the most accepted frontline treatment. And even if you're doing something like ACT or cognitive therapy, you're still thinking about and in contact generally with thoughts that are leading for you to feel more anxious or guilty or some sort of feeling of disgust in your OCD treatment. Well, if an emotional trigger like that triggers what I might call more of a trauma response, which means your limbic system kind of kicks in, it puts you into fight or flight, or potentially even like a freeze mode, and then you're not able to stay in contact with the actual stimuli that's more OCD related, then we might need to actually treat some of the PTSD symptoms first. Now, a pretty common presentation I see where I work is that how OCD might interfere with the PTSD aspects of it. And the two most common I see are people who have such strong obsessional doubt that they even doubt whether or not what happened to them that was traumatic even happened, or that they're trying to perfect the details about it to make sure they get it right. And it actually interferes with their ability to do, like I do mainly prolonged exposure, and it interferes with their ability to stay in the moment and try to connect with feelings and emotions that were present because they're so concerned about, wait, am I telling it right? Did this actually happen? What if I get this wrong? And then, of course, there is other types of more OCD-like behaviors that can interfere with treatment as well. I mean, if you fear contamination to such a great degree that, you're literally distracted in a session and you can't do either the cognitive therapy, prolonged exposure, or maybe you're doing EMDR and you're more focused on the fact that what you're sitting on is for a chair, who else sat there and could there be something on the chair that you're going to get contaminated with? So if one is stopping your ability to access the other, I'm going to switch over to that one and try to work.
And I think one of the questions we frequently come across is, especially when it looks like OCD, but it could be PTSD. So let's talk a little bit about showering. And I apologize for the echo. I've tried to fix it, so I don't know what's happening. It's my computer. But so for example, somebody has a sexual trauma and it hasn't been addressed, and a lot of their actual PTSD rituals are showering rituals, but it also really starts to look like OCD. And we're starting to treat it as OCD. Is it harmful if ERP is done and they're treating it as OCD, but no one's really addressing the PTSD?
Well, I mean, what I would want to know is, are they able to engage in the exposure as it's designed? Are they encountering, and it's hard to parse apart. Like, there's fear involved in most OCD exposures and in most PTSD exposures. But are they encountering, and this is what I think happens, is sometimes they're encountering a different level of exposure in that. So you're asking them to do something to challenge contamination, but it's triggering more of a trauma response. But they're rating the contamination piece of it as if you use a 0 to 100 scale, as a 40. But the trauma response is making it feel like an 80. Well, are they actually focused then on the contamination piece, or are they feeling so helpless and internally they're imagining more of the PTSD? So, if they're able to stay in that moment, well, I guess they could be potentially challenging the anxiety that's going along with the PTSD. But most of the time I see people, saying this is too difficult and it's too hard. And then as clinicians, we're like, gosh, but this is, I don't want to say only a 40, but it's a 40. So I would think it's more in the challenging but manageable range, but they're reacting like it's an 80 or a 90 or 100 even, but they can't even do it. And one thing I want to add here is many times, especially if you don't know someone's trauma history, perhaps they didn't feel safe enough to even share it from the beginning. We don't really know what's going on, and we think, we're wondering, are you ritualizing internally? Are you actually focused on what's going on here? Do we need to do more readiness work? And it's actually there's this heightened trauma response going on instead.
Makes sense. And so let's jump into a couple questions, and then we can kind of hop back to some of the pre questions that were submitted in advance. But one of the questions is from somebody in India, and they said, my question is about having repeated thoughts of being ditched or continuously living in that time of mind. Do you feel like this is part of OCD, or could this be more PTSD related? And of course, I just want to remind everyone, we're not going to answer treatment specific questions, and we're not going to be able to say this is this or that, but I think we could talk in general of, do these sort of thoughts sound more like OCD or more like PTSD?
And what was the first part? Their fear is?
About having repeated thoughts of being ditched or continuously living in that time of mind.
Okay, so I guess I'd want to know some more clarification on what do they mean. Like, did they have a relationship end? Were they left somewhere? Were they facing some things that might challenge, what's going on in like Maslow's basic hierarchy of needs? So like homeless, didn't have food. So I'd want a little bit more, and I realize you said we're not going to get into treatment stuff here, but at the moment it could be either or some combination of the two.
Yeah, and so I think what I would say is, if you can find a specialist, anybody who specializes in anxiety, it would be really important to do an assessment with them so that they can tease this apart and share with them, like, I'm kind of wondering what's going on, so they can ask the right pointed questions. Mm-hmm. So the next question, so somebody asked, how can I've overcome my panic disorder, how can I help? And so I want to encourage you, Nirmar, to reach out to IOCDF. We have wonderful advocate platforms and opportunities for you to help others and get connected. Okay, a couple other. So one is a question that's come, or somebody has made a few comments about having a past experience with an ex where they were physically abused, and having this, like, being really afraid that the person will find them and abuse them again. And I guess really, it sounds like that would be more PTSD. And so just curious if you have thoughts on kind of where to start and what they should do to access treatment.
Yeah, I mean, that does sound more like PTSD. Although, I would ask that person to, again, look for an anxiety specialist to see if they can help figure out what are some of the more distressing beliefs that come up when you think about that. Is it a fear for your safety, a fear for your life? Or is it that you really doubted your decision making in that relationship and how you could have put yourself in that situation? That doesn't mean that it's OCD with that latter description, but that means that it really could be either or. And what we're really looking at is what are some of your core fears about these situations? Because face valid, that might sound like PTSD, and it could be something that's really about doubting oneself, doubting that their next relationship is going to end up in that similar way, instead of it just being more of a life-threatening. I always joke, just being a life-threatening situation, because as if that's not a big deal. It's a big deal.
Yeah, it is. And again, I think this is where sometimes it's important for us to recognize that some things from face value can sound like PTSD, can sound like OCD, but there actually could be something else going on, or there's something else that needs to really be assessed and addressed. And that's why we always say you really want to see a specialist, because it's individually specific, right? Each case is different. So if you've had a trauma and you're trying to do OCD therapy, but you feel that nothing you do or no one can help make the OCD better, do you feel like the PTSD would need to be addressed first?
That's one potential thing that you might need to do. I'll give a couple of other suggestions though, are you working with someone that's an expert in at least one of the areas? It doesn't mean that they're going to know everything about all anxiety conditions, but are you using an evidence-based treatment, something that's been shown to work? So make sure you're starting there. And then besides considering whether or not you need to work on PTSD before or at the same time, you might look at whether or not you need a different dose of therapy. So is it possible, if you're working with a provider you're seeing once a week, or maybe it's every other week, can you step that up? Can you double that to twice a week, or once a week if you're going every other week? Do you have any options at all to look at even something that could be potentially higher care than that as well? You could always look at a second provider. It's really helpful though if providers can communicate with one another so they're on the same wavelength as well. So it's definitely a possibility that you might need to address that, or you might need to address it concurrently. Unless there's a really clear one seems worse than the other, I'll generally have people, especially in my treatment programs, address presentations concurrently. Now, and this next statement is very much my opinion. Unless someone's having like a panic attack and they're not able to engage in anything without having a panic attack, I'm going to start treatment for many things at the same time. But I might gear it a little bit more so their OCD is a little worse than their PTSD. Well, I'm probably going to be giving them, and I work at a level where we're generally seeing people 5 times a week for 3 or 6 hours a day. So we have a lot more time involved. But I might do 70% of the focus or 80% of the focus on the thing that's a little bit more interfering in life, we need to get more of a handle on first. And then the other 20% I'm doing psychoeducation, or maybe I'm building in some lower level exposures because I do a lot of more exposure-based therapies in both my professional and my private practice.
Yeah, and I think that, I think this is a really interesting piece of advice as well, because I think traditionally for people who say they treat OCD or anxiety, if their background isn't in CBT and in ERP, sometimes too, there's so much work spent on like history, right? Like I remember when I was first seeking treatment, there was so much exploration of like, did something happen? And like, let's talk about when OCD first started and what could have caused that. And, I think it's important that we talk just a little bit to that of, if the PTSD has been addressed and it's not treatment interfering and it's not problematic, is that a time where people can jump right into OCD work and not necessarily have to do both if they're capable?
Yeah, I really liked what you said there, and it just brings up a point that I see happen quite a bit where if we know that something's happened in one's past, first of all of our clients and all of us as human beings, we want to know the reason why. And I think it's worth talking a little bit about that, even though I really believe in evidence-based treatments and think that should be our first-line treatment approach for anything else. We should try to figure out a little bit, but we also do it with the caveat of we will never be able to recover like everything that happened to you and fully understand it. Stuff may have happened to you when you're 3 or 4. You don't have a good memory, even 6 or 7, and your emotions weren't well developed enough for your language system to actually describe what was going on. But we can try our best to go back to that point. But you brought up something else too, and that is when people have had something that's traumatic in their past. One thing that I use as a clinician is if someone says, I've dealt with that, so I don't need to talk about it anymore. I very much politely want to say, okay, if we are past this, then I would like to just spend at least a few minutes assessing what is it like for you to talk about it now, even if you said you addressed it, whether it's personally or professionally, months ago, years ago, decades ago, because if they don't feel like they're willing or able to go back and talk about that, it's very, in my mind, it's very likely that that's contributing to some of their, current interference potentially with their OCD work.
Yeah, and could there be avoidance there around just not wanting to address it, right? That's the important piece. So other tidbits, other pieces that you think are important. So in particular, I think that one of the things I'd like to talk about for a second is when there can also be a comorbid substance use diagnosis, and we see substance use start to come into play. Like, how do we address that if there's PTSD and substance use, or PTSD, OCD, and substance use?
Yeah, and again, I'll just put the caveat out there that I'm going to give you some of my opinions, and based on the setting that I work in as well, some of my decision-making processes, which I think will apply to most outpatient settings. But, take them for what they're worth, and what resources you have around you for the clinicians out there listening. it's pretty common that people either with OCD or PTSD or even the comorbid presentation might be using some sort of substances. Why? It helps them deal with the anxiety. It might help them get space from some of the more difficult situations that they're remembering or current emotions they're experiencing. People might be staying up late at night obsessing or fear going to bed, and it helps them in the very short term, be able to switch the channel in their mind to something else or lower their autonomic arousal system. So it's very understandable. I am going to look at how long someone's been using substances for, and how much, depending on what type they're using, that might dictate some of my treatment recommendations for, do we address it all at the same time, or do we need to do some things first? With most substances that I expect there to be a significant withdrawal effect, those are not times where people are very receptive to learning new material. And I don't mean they're unwilling to, I mean literally their mind and their body are saying, I have intense cravings. I don't feel well. For some things, you have withdrawal effects where you're actually literally getting sick. So to say you should do some exposure work during that time, or even cognitive processing, you're just not going to pick that up as easily. So depending on how bad the substance use is, I might say you need some substance use treatment first. But of course, once you do that, and this is the reason why I often recommend some concurrent treatment if possible, is because when you start asking someone to removing their coping skills, so compulsions are a coping skill for feelings and obsessions. Avoidance and other things, hypervigilance, are a response to feeling helpless with PTSD. Substance use is a potential distractor, avoider, and dampen your autonomic arousal system. Once you start asking someone to give up and become more vulnerable, one of those coping skills, what you will see is almost an automatic reaction to try to engage in more coping skills in a different area. And I know you brought up this in the context of substance use, but it also happens with co-occurring eating disorders. When we ask people to do trauma treatment and they have a co-occurring eating disorder, and if you're not focused on that, you will see more disordered eating behaviors. You'll see more restricting, you'll see more binging, sometimes more purging, more exercise. So, it almost seems like it starts coming out somewhere else. And that's why I say you might need to do like an 80-20 split. I'm going to engage, in most of this area, the most distressing one, but I'm going to make sure that we are not letting the other areas actually kind of like act up.
100%. And I want to just kind of give a couple resources. There's a clinic. So our clinic here in Houston at McLean Houston, it's a satellite type of clinic, right? We don't have the resources that Rogers and Milwaukee has, or that McLean in Boston has, to where if somebody has a co-occurring substance use disorder or even PTSD diagnosis, they can start at other units in more intensive levels of care and start OCD work and transition. And so that's why clinics like us, people say, well, why do you have a 90-day sobriety requirement, and why can't we do it together? Because we're not set up for it, right? Where there's clinics that specifically are. And so that's one of the reasons I want us to just make sure everybody knows we're not saying you can't get OCD treatment. We're not saying you can't start that work. But there are programs like Rogers, like McLean in Boston, and programs that have this comprehensive, but also like subunits than just OCD that can appropriately address it. But starting on just an OCD program, if you have an active substance use disorder or active PTSD, like that might not be super useful.
Right, absolutely. And I don't want to over recommend some of the institutions we represent, but it gets back to that the dose, and sometimes the dose is the amount of therapy specifically for one or both conditions, and sometimes it's having a dose of exposure therapy or cognitive therapy or even EMDR, and then adding something else like substance use treatment, and one of the more evidence-based approaches for that.
Absolutely, and I think Anita also has a program that's both. So next question is there a difference in exposure treatment for safe showering over wiping not feeling right if you had an assault trauma, but also been diagnosed with OCD? And again, I don't know that you could answer for this specific question, but in general, right? I think we'll kind of, can there be shower rituals that could actually be more attributed to PTSD, even if you have had a past assault, even if you have a diagnosis of OCD, or would you say that lends more towards OCD?
Yeah, I mean, this is something where it could be intertwined to some degree. And, I mentioned this before. We can try to identify, like, when did this start? What were some of the beliefs that happened, either during or after? Some of the times you notice it was more difficult, or you felt like you needed to do more safety behaviors. And I like using that term because a lot of our rituals are actually to try to promote some safety for us, and that kind of covers both OCD and PTSD responses. I wish I could give a better answer than we really don't know, but it's very possible that it's a combination of the two, or that, and one built off the other one. So it started off as contamination, but it could be, think about the traumatic event itself that happened to you. Let's just say it resulted in you being physically injured and seeing blood. And even if you just washed off a body part in the sink after the event, or you showered after the event, it's not like the trauma stopped and now you're in a safe place. It's, whatever you're cleaning, that's a reminder of what happened or what got injured. So again, it's if you already had some predisposition to OCD or OCD present, it's likely going to intertwine to some degree.
That makes sense. So one of the questions was we have two OCD based questions. So one is about religious OCD, and I'll kind of start, and then you can share your thoughts as well, Dr. Wetterneck. But really, ASRAF, for this type of OCD, we would recommend exposure with response prevention. This type of OCD is called scrupulosity. So it's really the form of OCD that takes on or starts to interfere with religious, faith-based practices. And the goal of exposure and response prevention, as we talk a lot on these webinars, and again, we'll be doing specific webinars. So down the road, I think we're going to do webinars focused on different subtypes of OCD. So scrupulosity, harm OCD, sexual intrusive thoughts, kind of you name it. So hopefully we'll have some more detail, and we've done some as well. But really, again, it's about how can we remove OCD so that you can have a healthy, functioning faith relationship where OCD doesn't interfere. I think one of the biggest anxiety that I see with patients with scrupulosity is, well, I don't want to do the work if you're going to make me less religious, right? My faith is really important to me, and I don't really want you to change that. And so my emphasis that's really clear is that our goal is not to change your faith relationship. Our goal is not to make you less faithful, but instead to actually make you have a healthier, functioning relationship with your faith that isn't controlled by OCD.
Yeah, I think that's very well said. And something that I like to add when talking about scrupulosity is having someone look at their core values. And so, the concern that you brought up that's pretty common is you're going to affect some of my core values, including my relationship with a higher power. And it's really to help them sometimes see, are your core values currently affected by that? Whether it's with the kind of like the domain of spirituality and religion, but also your core values oftentimes with other people or other things that are important for you are already being affected by some of the safety behaviors you're employing. So there is an effect happening, and what we're trying to do is show you that in the short term, if you're able to challenge that, then you can have stronger faith-based and other values-based relationships after you go through treatment.
100%. And the last question we'll hop into is, what if you have many areas to focus on? How do you focus on all of them? If your OCD is very spread out in multiple areas and does seem to jump. And I'll start by just saying, Sherry, that this is very common, right? We know that one of the actual common criteria of OCD is that it waxes and wanes, symptoms come and go. And so one week we can be focused on contamination, and the next week we're like, we don't care about that anymore. All we're worried about is if we're going to, hurt somebody we love. Can you speak a little bit, Dr. Wetterneck, to how common it is to have different areas of OCD, but how do we treat it? How do we still treat somebody if OCD keeps shifting or jumping?
Yeah, very common. I mean, it's, for some people, it can be really a focus on just one thing. But for most people, I mean, even look at some of the research, like many people start off, in fact, most people will start off with something contamination related in their history, and it can morph into many different things and not even maintain as something that's a contamination based fear. So very common. And what I like to do is I want to try to address, so, if we're doing the core treatment right, we are trying to tap into their anxiety related to some of their beliefs. So what are their current core fears? Can we work on them? And, sometimes people might look at it as, okay, so we're helping you with this one belief or this other belief. Well, sure, but we're really teaching you a skill that translates across most of your beliefs. So what we're teaching you is giving you another tool for your toolkit, but that tool is like a Swiss Army knife, and it has different applications that you can apply to the different types of OCD. So let's say you have contamination and scrupulosity and maybe some taboo thoughts about harming someone else. Whatever you're presenting with at this moment that's most difficult for you, we're going to work on that. And then we're going to tell you, you now have the skills to work on the other things as well. And it's about trying to connect the times they need it the most with employing those skills. And that could mean that, maybe you go through treatment and you work on something and you're successful in that. And then you either cut back on sessions, or maybe you just do some sort of maintenance and, you have your therapist on call. And when something else starts coming up and you're not sure if you can challenge it on your own, maybe you start therapy again, or maybe you do like a maintenance session where you get some advice on exposures and build a separate hierarchy for the current area. But you already have that skill set then built in. And it's about remembering that and pairing it with your current approach. Now, of course, you could be so anxious at the time that you do need the help of your treatment professional or someone else to get you engaged in that. But I see it as if people can recognize they learned it once, they can learn it quicker a second time.
And I think, this is actually something that Ethan Smith and myself are just so passionate about, because we see it time and time again where individuals will leave residential treatment, they're doing really well, and then automatically, a couple months later, they have a new trigger they've never experienced, and their go-to response is, I've relapsed. And my response is always, well, tell me about it. It's like, well, I have a new symptom. I don't know how to treat this. Like I didn't do this in treatment. My response is always, yes, you do, right? Treatment doesn't change. And so if it falls under the umbrella, we treat it with ERP. It doesn't matter what type of OCD it is. And this is why I think it's so critical for us to really think about, what are we treating at the core when we treat OCD, right? We're not treating scrupulosity. We're not treating harm. We're not treating these individual things. We're treating uncertainty, right?
Yeah.
At the core, that's what we're treating. Any subtype you have, we're treating uncertainty. And when you can acknowledge that and see what you're treating, then when a new symptom or trigger comes up, if you're automatically engaging in ERP versus giving in and searching for certainty like OCD wants, you won't see it have the power that other symptoms have for treatment.
Yeah, very well said. Mm-hmm.
So thank you so much. It's been a wonderful talk today. Any final kind of comments or thoughts or resources that you think would be really important for us to make sure for those who might live with comorbid PTSD and OCD, or that are wondering if they have a PTSD diagnosis, could use or access?
One thing I want to say is just don't give up on the idea that your life can change and get better. And there are so many things that go into therapy. And Dr. McIngvale, you pointed this out time and time again. There's evidence-based therapies. We do ERP for OCD. There's a couple for PTSD. There's so many more things that go into what could get you better. And sometimes it's the match with your therapist. Sometimes it could be the fact that you tried a third time or a fourth time, and then you were more ready and something changed in your life. So don't only look at things that have prevented you. Keep searching for something. And I don't mean like see someone for one session and go on to someone for the next session, but there is hope out there. I do believe that there'll be a good match for you if you keep looking. And it could be about adjusting the dose, someone that might be able to see you more than once a week, or finding a program. And one last thing to consider is, if this has disrupted your life so much that you cannot have like a life worth living, then it's worth doing whatever you need to do, even if it means moving to somewhere that has a program that's more intensive. Doesn't have to be residential. It could be a partial program, an IOP program. But if you go to that program and it helps you, 5 years from now, you're going to look at that as, I paused my life for a couple of months, and 4.5 or more years later, as long as you maintained your treatment approach, you're going to be better. And so I know it's a price to pay, but in the long run, it's worth it.
I couldn't agree more. The slogan I always end with is that help and hope are always available. And I think in particular, when we think about the journey from symptoms to appropriate treatment for OCD, we know it's often 12 to 17 years, which is crazy. We're all doing the work that we can to reduce that. But if at year 12 you quit searching, but year 13 or 14 is when you would have gotten the right help, right? It's worth pushing through. And I think the important thing we're talking about is that evidence-based treatment means that there are treatment modalities that are scientifically based, that we know are rooted in research and that show efficacy of working, right? So that means that there are treatments out there that work and that can help get you to a different place and help reduce your symptomology. And I want to say the push I always have, and the most unfortunate kind of piece of our field, is that people can also say they treat OCD, say they treat PTSD or anxiety, and they're not doing evidence-based treatments. Yeah. And you wonder, well, I'm not getting better. It must be me because this provider can't help me. And that's not always the case. And so I think what Dr. Wetterneck and myself are saying is, find somebody who engages in evidence-based practices, give it a shot, and keep pushing, because the right treatment is out there for you, and it's critical that you keep searching to find it, because when you do, you can get your life back. So thank you so much, Chad, for coming on today. It was a pleasure. It is recorded, so this will be posted live after on iocdf.org, where you all can find it. Of course, please visit iocdf.org for more resources and information. We are so grateful for your time and your expertise. Thank you for joining.
Thanks, Liz.